I was asked by the group to talk about some things that I think I know about acne that are unpublished. And those of us who worked with Albert know he's the man who invented the horizontal priority list. You'd have a discussion with him in the morning about something, and 4 o'clock in the afternoon he'd say, well, where the hell are the results? He says, we just haven't started yet. And he would say things like Gert said, you're hopeless, you'll never make it to 40. Then when I was 40, you'll never make it to 50. You have to get these things done. So anyway, we did a lot of things over the years that we never got around to publishing, and I thought about it a little bit, and I brought some that maybe you'll find interesting. And how about this one? Do you think sebum reduction occurs with minocycline therapy? Well, it can. And the way that went was that we had patients who observed that they thought their skin was less oily after their inflammatory acne improved on minocycline. This is in the early 70s. Minocycline was a major, major step forward. So we did some studies. We treated a group of patients with bad acne with 100 milligrams twice a day, measured sebum reduction, found about a 40 to 50% reduction. So we then did 15 non-acne patients and 15 patients with mild inflammatory acne and saw no effect. So we concluded that perhaps inflammation may have some ability of amplifying sebum production, and kind of left it there. We thought about publishing it, but we knew we'd never get it past John Strauss, because he would say, that's got to be wrong. And he'd be all over us the way we measured sebum reduction. And so we just kind of left it. But I think more recently there are some findings that offer at least a plausible possible explanation, and it may be that by suppressing the inflammation of acne, which probably leukotrienes are involved, could be the key to this, because there's a drug, a 5-lipoxygenase inhibitor, which decreases leukotriene B4, which is a PPAR gamma agonist, which can have activity on sebaceous glands and potentially increase sebum. And the arachidonic acid pathway, as about just about everything else, is present in sebocytes. So it may well have been that the suppression of inflammation was limiting or decreasing the amount of leukotrienes present, and that's why we saw this decrease in sebum. So there's one thing that I think I know. Here's one I know for sure. Photodynamic therapy and lots, I haven't looked at everything, but lots of people have come to me and said, we want to measure, we want to separate ourselves from the other people. We want you to measure the reduction of P. acnes. There's no question if you, with blue light, for example, in vitro, the copoporphyrin of P. acnes, you expose the organism to blue light, you can kill it easily. So we've done multiple studies with several devices looking at rapid, looking at 1 hour, 5 hours, 1 day, 4 days, treatment every day for 3 weeks. We've never seen anything, not a hint. So if there is benefit in acne, the studies for most of these devices are, shall we say, limited, not anywhere near as rigorous as drug studies. Assuming that there is some benefit, and there may well be, it must be due to other mechanisms, because we can't find any effect on P. acnes. Let's talk about anti-inflammatory effects of antibiotics again, which I showed you a little bit. Where did this come from, other than the in vitro findings, which are relatively more recent? But the idea that antibiotics have in vivo anti-inflammatory effect in acne has been around a lot longer than some of the assays, the more recent assays. I think it goes back to the benzoyl peroxide erythromycin, which was a creation of Alan Shalita and Dermick, which was a brilliant suggestion, that under patch tests, and I'll show you what that looks like in a second, there's a difference, and it suggested, and it seemed reasonable enough, and I think people bought into it quickly, that erythromycin was having some kind of anti-inflammatory effect that made benzoyl peroxide more readily tolerated. I didn't believe it, and Dermot got me to do it, and I got the same results, so the results are the results. I can tell you now that Dermot is sort of fading, that I did it benzoyl peroxide clindamycin, and there's no difference in the irritation. And I showed you that no effect on papules that Jim didn't like, probably because it argued against his thesis. But here's the stuff that where you have benzoyl peroxide in the magenta, and then you have here the vehicle, and here's the combination. So there's no question. There's a big difference under patch test. It's curious why that should be. You don't get that with clindamycin. And I think that's where the concept kind of crept into our culture. And then with the findings of these in vitro findings that are very suggestive and very attractive to suspect that there may well be some in vivo anti-inflammatory effect. But as I said, there really are no studies. Not that there is minimal evidence. There are no studies, let alone evidence. So, but we won't go over this as we did that already. Let me talk to you a little bit about scalp acne. Gerd and I stumbled upon this, we thought, a long, long time ago. And often the diagnosis is folliculitis. Well, of course, acne is a folliculitis. Staph aureus is a folliculitis. So folliculitis just means inflammation in and around follicles, and it's not a specific diagnosis. So actually, Howard Maybach described many, many years ago, right around the time we were beginning, right? And he called it C. acnes folliculitis. It used to be called Corynebacterium acnes before the methods for classification got better. It was realized that this organism wasn't a Corynebacterium, it was a Propionibacterium. So multiple cultures showing nothing like Staph aureus and only growing P. acnes was what Maybach reported. But it occurs, and you can express a microcomedo. So you can get lesions like this, and you might think that this one here is a Staph aureus, but it isn't. And you can, if you biopsy these, you have the remnant that tells you it's an acne is this accumulation of abnormally desquamated material, the microcomedo with secondary inflammation. And you can even at times see non-inflammatory open and closed comedones on the scalp. So scalp acne is actually much more common than I think people realize. I think it occurs most commonly on the nape of the neck and around the side of the head, but I have seen it on the top of the head as well. And I've collected, I guess over the years, I collected certainly more than 50 cases and never got around to publishing. So that's something I think I clearly believe to be true. Now, how about antimicrobials, antibiotics, and comedogenesis? All studies with benzoyl peroxide or benzoyl peroxide antibiotic or clindamycin have always shown a decrease in comedones. We didn't trust that or believe it, and Albert used to say, people who do studies are idiots. You know, they don't know how to count. Of course, he never counted a lesion in his life. In fact, right, Gerd, I tell this story and people say, that can't be true. He put Gerd and me and Jim Fulton in this clinic. He gotten a grant, and the three of us saw patients 3 days a week, right? It was Tuesday afternoon, Saturday morning, Tuesday and Thursday afternoon, or maybe just Thursday. Anyway, we saw about 300 patients, something like that a week, the three of us. He never came, ever. So we just started doing things. We started biopsying this and culturing that, and he used to send us bottles of stuff to treat patients with. And one of them turned out to be vitamin A acid, or tretinoin as it's now known. And just by sheer luck, it was sent in dark bottles because nobody at that point knew that tretinoin was photolabile. So rank beginners like Gerd and me, we thought this stuff worked. It was a little irritating. You know, especially the 2%. That was really irritating. But they got better fast if they survived. And then after about 6, 7 months, all of a sudden it didn't seem to work anymore. And it took us quite a while to figure out maybe it's the bottles. And it turned out it was the bottles. So anyway, to get back to this story, we looked where we counted and recounted and counted and recounted non-inflammatory lesions and then treated them with 1% clindamycin, and we had a 20–25% consistent reduction. So then we took 15 kids with early acne, which is non-inflammatory, as you know, usually in the midline, and as you probably know or should know, at that stage there is no P. acnes. It's not until later that P. acnes colonization takes place and then inflammatory lesions develop. So we treated them with a topical, this is more recent, we treated them with a topical benzoyl peroxide clindamycin. There's absolutely no effect. And there's no effect in the rabbit ear where there's no bacteria. So we concluded that just as we did with the studies that with minocycline and sebum, where we concluded inflammation could amplify sebum production, we concluded that P. acnes may have some ability to amplify or intensify comitogenesis. And the more recent studies, I think, have completed the circle and give us a reasonable way of thinking of why that is the case. Bill Cunliffe's group some years ago showed P. acnes stimulates IL-1 production from keratinocytes, which now we know involves toll-like receptor interaction. And Terence Keeley showed that IL-1 in his organ culture system would induce a retention hyperkeratosis, very similar to what you see morphologically in acne. So we think that's the mechanism. So if you reduce the organism that's producing something like IL-1, and who knows, maybe something else that can intensify that aspect of abnormal desquamation, it's not unreasonable that reducing the organism should have at least some benefit on that aspect of acne. And here's another one that interested me over the years. This is a kid who's on cyclosporin and Dilantin, who's got this horrible, horrible, horrible acne. And Dilantin and acne is not uncommon and often associated with gingival hyperplasia, as is the case with cyclosporin that produces gingival hyperplasia. So at one point we got interested in that, and there actually was a foundation that would support any kind of work on Dilantin. I think it was called the Dreyfus Foundation. And we got a small grant, and we did some studies, and here's one that I dug out that I remembered us doing where we were giving Dilantin. I can't remember how long it was. It was a couple of months, about 2 months. You can't do these kind of studies nowadays too easily. And we measured sebum excretion rates, and we found an increase in these people, and we thought, well, that would make sense, but we didn't have any way of understanding or even hypothesizing why Dilantin might have an effect on sebum production. But now there is a way, I think, that involves fibroblasts, because fibroblasts are clearly involved in gingival hyperplasia, I would think. And we know, here's a cartoon from Zubilus's beautiful review in the JID recently. There's a syndrome, APERT syndrome, where there are mutations in the fibroblast growth factor receptor 2B that's associated with acne, a very interesting association. So it may well be that Dilantin is acting through fibroblasts, which are acting through this receptor for fibroblast growth factor products. There are a variety of them, as you can see here. There are 3 that are described here. That's a hypothesis, but I think it's not an unreasonable one to help explain why Dilantin can be associated with acne. The last thing I thought I would talk about is some of you know, before emails, the younger ones won't know this, but before emails, when we used to call each other all the time and miss each other and call each other, and those who were involved in that know that for the last 40 years, I've had twice a week, I had 1 hour, Tuesdays, 12 to 1, that were my thinking hours. I was unavailable, unless somebody died. or something really serious. Now that I'm emeritus, I go to the gym every day, so I have a daily 1 hour thinking when I'm on the treadmill. And maybe I should have done that earlier, because not too long ago it suddenly dawned on me. But something that's been bothering me for a long, long time is, why does acne come when it does, and why does it go away? And the reason it bothers me is that sebum excretion rates and P. acnes levels in adults are similar to those seen in teenagers with acne, yet they don't have acne. And that's the same time that acne patients, by and large, not 100%, but by and large, that's when they get better. So why is it that adults get what teenagers have and have a disease, and when their age-matched controls become adults, they get the same sebum and the same P. acnes kind of levels, yet both groups now don't have acne? So that's always kind of gnawed at me over the years. And here's just an old slide from one early paper that we did looking at, it's cut off a little bit, but these are different age groups. So these are teenagers with and without acne. These, you're getting into the 20s, and then I think it was 30 to 40. And these kind of changes are absolutely similar to what John Strauss and Peter Poche showed for age-related changes in sebum production. So here we have P. acnes, high levels versus those without the disease, high levels of sebum versus very low levels in those without the disease. And later, everybody's got the same, roughly the same levels of sebum and P. acnes. So that's suggested to us a long time ago that there may be some changes that are occurring with age in follicles, in sebaceous follicles, that help explain why acne goes away or why acne comes when it does. So to make a long story short, some other observations. Acne patients, particularly males with significant inflammatory acne, often look more mature, I felt, and girls too, often look older and more mature than their age would suggest. And it, clearly obvious, once you see it, then you just can't not see it. These individuals, if they're males, often are shaving and can grow mustaches, you know, when they're 14, 15, and their age-matched non-acne friends, you know, are really maybe just beginning to shave a little bit when they're 17 or 18 and don't really shave on a regular basis till somewhat later. And I think these people with males with significant acne, they develop body hair, to my looking, on their shoulders, chest, much, much earlier. So that hair, that's an androgen-driven tissue. It's a different follicle. So my hypothesis is, could acne be a premature maturation of skin with early expression of androgen receptors at a time when they are having cyclical bursts of androgen plus growth hormone-induced insulin growth factor type 1, which can stimulate, we know, as can insulin, can have a stimulatory effect on sebaceous glands. So if they have early expression of androgen receptors and are responding to androgens as well as to growth hormone IGF-1, that might explain why they're developing sebum and P. acnes at an earlier age. It wouldn't explain why acne goes away or why others don't get it when they get older. But before we go into that, here's the first person I ever treated on protocol with Accutane. He just got his license because he drove to the clinic. He loved, and he's now, I don't know, he's in his late 40s. But here he is at 16. He looks, you know, he's got a nice beard and a mustache, and he looks a little more mature. And here's another one of the early Accutane patients with hair on his chest that you don't see in most males until their late 20s, 30s. You know, it's very striking once you see this. And that, as I say, clearly is an androgen-driven tissue also. This kid's 14. I mean, he looks young, but he's got a nice, nice mustache, and he shaves every day. So what's that all about? So my thinking is influenced by a really interesting guy in the Midwest who called me. He also called Diane and some others. Everybody else blew him off because he sounded a little strange. But I said, yeah, glad, come on over. I've talked to anybody. So he came and spent a day to me, and he walked in, and he sat down, and he opened up his briefcase, and he brought out some paper. He said, I want you to know that comedogenic can be explained by the following equations. And I looked at them, and I said, absolutely. What the hell are they? And the top equation is Bernoulli's principle. And the bottom one is Laplace's law. It took me about a year to look them up and start to, think about them. As some of you know, I did go to medical school, but I never had any science courses in high school, and I took 2 in college. So it took me a while I never had any physics, so it took me a while to get a feel for what he was trying to say. And after a while, I had a feel for it, and some things that I had been thinking about and worrying about, like why does acne go away, which hadn't crossed his mind, began to sort of percolate. And I'd call him periodic, and we'd have discussions, and I'd understand some of what he said, and he'd understand some of what I said. And then gradually I came to this hypothesis. So here we have sebaceous follicle. We have all these big, large sebaceous glands into their lobular ducts and then feeding into the central canal. Now, best way to think of this, for me, was to think of a balloon. You have a balloon where you have a neck and you blow into it. The velocity of air is greatest in that neck-like area, but the pressure is exerted in the larger portion of the balloon, so the balloon blows up as you blow. And I think here you have the big sebum production, high velocity, and then you start to get this area expanding. And the Laplace's law explains the pressure and tension that is applied on the wall of a cylinder. And there's a very interesting paper in the JID showing that stretching and tension on the epidermis results in hyperkeratosis of the stratum corneum. So here's my hypothesis is that that's why acne's coming. My hypothesis is there are androgen receptor expression, so that testosterone, and remember at this age it's a cyclical burst-like thing. That's why there are often associated mood-like swings. So you have sudden bursts, perhaps, of sebum. Also, you have insulin growth factor 1 via the liver and the stimulus from growth hormone, both driving this gland, and you're blowing up this balloon and putting pressure on the wall, and off comes this abnormal hyperkeratotic sloughing, and the combination together form what John and Albert called the microcomedo or microcomedone. So, okay, but how about why does acne then go away, and why doesn't everybody develop acne? So we have this high pressure of sebum, as I say, and the tension results in this secondary change. Now, Bob Lafker and I made an observation back in the 70s. And once you make this observation, you can't do any more looking because you're so biased, that's all you're going to see. And you can't tell anybody other than your friends that you think you've made this observation. We thought that the stratum corneum in sebaceous follicles looked much more prominent we followed some patients prospectively, and we looked at a bunch of those in their 20s versus those who were teenagers. And we thought there were anatomical differences, but we knew we couldn't try and tell that to anybody. Now, so where does it come with this, Bernoulli's principle and Laplace's law? Well, one thing that's been shown by a variety of people in different ways is that with age, there's an increase in the size of pores. So I called up Chris and I said, what do you think would happen if the cylinder, in this case the pore, gets bigger? And he said, oh, there'd be a lot less pressure on the walls. And I said, well, maybe that's why acne goes away. And then he said, you know, I think you're right. So the physics of sebaceous follicles and the hydraulics, if you will, could possibly be changing. As you get into your 20s and now you're no longer growing, so you no longer have the growth hormone IGF stimulus, and you have a cylinder that's getting bigger. And therefore, it's more difficult to get that kind of blowing up the balloon type phenomenon. May explain why acne diminishes and tends to go away. And it may also explain why others who never had acne as teenagers and now have it, assuming that's when they express their androgen receptors, are now able to respond to androgen stimulus, which we know is more even and not as cyclical and burst-like as it is in the teenage years. And they have a larger cylinder, and they don't have IGF, insulin growth factor 1 stimulus, and they have a large enough cylinder to accommodate that without difficulty. So this, I don't know if those of you up front can see this, but this is the kind of pores that you tend to see, much larger in people who had acne. And you see the size of pores in general, as all women know, their pores are larger on their nose when they get to be in their late 20s. They all think they have blackheads. They squeeze their nose, and there are all kinds of very effective cosmetic products available at large sums of money to treat the normal nose. And along the sides, they tend to be clearly larger. And here, and women develop what they call the T-zone, is really the I-zone of sebum production of oily skin. And I think acne patients get it much more diffusely across their face. And it's the change in this cylinder, in this pore, that allows what at a younger age, with double stimulus of testosterone and insulin growth factor, to produce a pressure on the side of the wall and the distension that we see microscopically in the preclinical stage, and we see at a much more extensive stage when you have clinical non-inflammatory lesions, that then also provides the environment for the organism P. acnes to proliferate and generate its pro-inflammatory molecules, so that some follicles then go on to become inflamed, that accounts for why acne occurs when it does and why it goes away when it does, and why others don't get it, even though they have sebum and bacteria levels that are comparable to what teenagers with the disease have. And I think that I anticipated we'd be late, so I didn't belabor this too much. So there's my review of some things I think are true that have not yet been published. Thanks.